Let me uh, talk about some respiratory emergencies and chest tube. Due to some unknown reason, the NCLEX board like asks a question from chest tube. We are going to discuss about some question and answer, and also I will try to print something in your mind. I believe you will like it. First of all, talking about pneumothorax. So what is pneumothorax? Easy way to explain. When lungs collapse due to air in the pleural space, we call pneumothorax. Pneumothorax is a respiratory emergency. If you ask me, what are the other respiratory emergencies? It is here. You say pneumothorax is one, tension pneumothorax, hemothorax, and flail chest. First of all, pneumothorax. Easy way to explain, when air inside the pleural space, we call pneumothorax. And the medical terminology, when lungs is collapsed due to the air in the pleural space, we called pneumothorax. The key symptom, we get hyperresonance during percussion. Then another word is called tension pneumothorax. But if you ask me, if in the lungs fluid accumulate, what we called? If blood accumulate, what we called? So if air accumulate, pneumothorax. If blood accumulate, hemothorax. When water accumulate, we call pleural effusion. Another emergency is called tension pneumothorax. So tension pneumothorax, it means air enter the pleural space during inspiration, but cannot expel out during expiration. And the key symptom, trachea is deviated. It is tension pneumothorax, one of the emergencies. Hemothorax, when blood is accumulated in the pleural space, we call hemothorax. The key symptom, dull on percussion. The last one is failed chest. What it is? What does it mean, failed chest? If the chest wall is expansion limited due to multiple fracture of the ribs. Let me explain. Like someone is injured, car accident, all of the fracture is broken, and lungs is collapsed or lungs is bulging outside. When chest wall is expansion limited due to the multiple fracture of the ribs, we call flame chest. The key symptom, paradoxical chest wall movement. So you can see there are 4 factors or condition we call respiratory emergencies. Now let me go little bit more about the pneumothorax. Pneumothorax increase the air or fluid in the pleural space and also increase the thoracic pressure, decrease the vital capacity of the lungs. The amount of air you can take is forcible, easy way to explain. If anybody have pneumothorax, the common sign and symptom, they complain shortness of breath or respiratory difficulties, we call dyspnea. Tachycardia, increase the heart rate. Tachypnea, increase the pulse rate, or chest pain, and also absence the breath sound on affected side, or hyperresonance. This is the key point. Hyperresonance we get during percussion. Decrease the chest expansion on affected side, and also subcutaneous emphysema develop. Trachea deviation to unaffected side. When trachea is deviated and air enter in the pleural space during inspiration but cannot expel out during expiration, we call tension pneumothorax. So if open wound occur and definitely suction around the heart in the chest, okay, so sucking sound heard, or mediastinal shift towards unaffected side. These are the findings. Now you can ask me, what is the nursing intervention? What we could do? Our first job, give the oxygen. Then medication like bronchodilator, and also give them opioid if they have a chest pain, and finally chest tube for pneumothorax or hemothorax. Let me read it. They said, my first job, high Fowler position, patient positioning, then monitor the vital sign, oxygen is prescribed, take a chest x-ray for evaluate, and dressing over the open wound, dressing, and also prepare for chest tube placement, right? So now we are going to focus on chest tube. That is super important for NCLEX board. Chest tube, if I ask you, what is the function of chest tube? You can tell me to remove the air, to remove the fluid from pleural space, right? Or you can tell me, when pneumothorax, we use the chest tube. When hemothorax, we use the chest tube. Sometimes patient have both, like patient have a air inside the pleural space, or patient has a blood inside the pleural space. If the both blood and air in the pleural space, we call hemopneumothorax, right? Something is very important we have to know. The normal breathing works on negative pressure. Okay, so let me tell you, this return the negative pressure to the lung space, my friend, because normal breathing works on negative pressure. So my chest tube target to return back the negative pressure, remove the fluid or air, and promote re-expansion of the lungs. So the chest tube have a 3 chamber. This is chamber 1, 2, and 3. But there are other name of each chest chamber. So you see the chamber 1 we call drainage collecting chamber, drain collecting chamber. 2 is called water seal chamber, and 3 is called suction control chamber. So chest tube, let me show you the picture. So here you can see that use a chest tube. one way attached to the lungs, affected lungs. You see the pleural effusion, ER, and this one is suction control chamber, and this one is a water seal chamber, and this one drainage collecting chamber. So if you see this picture is more clear, this one is a drainage chamber, and this one is a suction chamber, and this is the water seal chamber. This is the most new one what we use in our hospital. But before we use the chamber like this, so let me explain one by one what we need for the board. First one, chamber one, we call drainage collecting chamber. So they collect the fluid draining from the client. So the what the collection come inside the drainage collecting chamber, we chart the amount and we check the color of the drain. Okay, so you see, check the amount and color of the drainage. And we should report if we see the collection more than 70 milliliter per hour, then we talk to healthcare provider. But some books said if more than 100, we have to inform healthcare provider. Okay. So again, let me tell you, the collecting chamber, we could record the drainage. Every 8 hours, we could record. And we could notify if the drain greater than 100 ml per hour. So if we see the collection is bright red, we have to notify. So when the collection is a bright red color, it indicates hemorrhage is occurred inside the body. So next, the chamber 2, we call water seal chamber. What role? It is served as a water seal. Okay, so keep in mind, in water seal chamber, we always add sterile fluid up to 2 centimeter line. So in this picture, I can show you, this is the water seal chamber. Always we have to keep 2 centimeter line sterile water and check every 2 hours. And also chamber must be kept upright and below the chest tube insertion site. So it is chest tube insert here, and this chamber is just below the chest, right? And also keep in mind, tidal expected and lack of tidalling, lungs re-expand or obstruction. So now if we see the continuous bubbling inside the water seal, it indicates air leakage. So let me recap it. In the water seal chamber here, so here I said, you basically water seal, nothing come in air. So this is the chamber. If we see continuous bubbling, indicate air leakage or bad sign. Intermediate bubbling in the water seal is a good sign. Now go here, let me read it. Excess bubbling or continuous bubbling indicate air leak. If there are no fluctuation of the water line or assess the lung sound, and we called healthcare provider. There may be obstruction or lungs have re-expand. Now let me go and read the another chamber. It's called, and it is called here. This is called suction control chamber. Keep in mind, in the suction control chamber, if we see continuous bubbling, it is good sign. Opposite the chamber 2. So chamber 3 is the suction control, and suction set at 15 to 20 centimeter as prescribed, or some book wrote 20 centimeter water is common, and nurse should see gentle continuous bubbling. And when we say continuous bubbling, this is the good sign. So this is the suction tube here. So again, I said continuous in sucking, or doctor determine how much suction need for the patient. Again, continuous bubbling in the suction control chamber is a good sign, and intermediate bubbling in the suction control chamber is a bad sign. It is totally opposite in the water cell chamber. Now go here, some note about the chest tube. So we could monitor, right? We could monitor the respiratory status. Now I'm going to explain two more things. One is nursing care, and also what we have to follow during the removal of the chest tube, right? And also what are the complications? Let me explain. So first of all, monitor the respiratory status. Maintain the dry, sterile, occlusive dressing. Chest tube label bottle with a date and time, and tell patient to expel pain when they cough. If the drainage more than 100 ml per hour is excessive, we notify the healthcare provider, and have the clamp at the bedside for emergencies. Never clamp unless the system breaks. If the tube disconnect, place the tip in the sterile water until the system can be replaced. Two chest tube on the same side, or top drain air and bottom one drain the fluid. So now let me recap it first. So nursing care, I said, we always assessment the chest tube insertion site like this one. Insertion site, we check for any kind of erythema, pain, or crepitus. Position of the patient is always semi-polar or high polar posture. And we obtain the chest X-ray to verify the tube placement. And also keep the two hemostat or sterile water or occlusive dressing at the bedside. And also one clamp when ordered. Do not milk in the tubing, right? Now going to talk about the chest tube removal, right? Say remove of the chest tube. So have the patient inhale and then exhale. So during removal, it is very important to educate or teach your patient before start the procedure. So what we could do, tell your patient to take a deep breath and expel and bear down, right? And this is called Valsalva maneuver. Or take a deep breath and hold it. And during hold it, and also during removal, we tell to follow the Valsalva maneuver. If you say what is Valsalva maneuver, tell take a deep breath, expel and bear down, or take a deep breath and hold it, right? During the removal time, we apply that sterile petroleum jelly gauze dressing over the chest tube site. So place occlusive Vaseline dressing on the site and place on unaffected side, obtain the chest x-ray. That's it from here. Now, sometime NCLEX board asks, and I want to share with you before go the next steps. Some point about care of a client with a chest tube. First of all, what we could do about the assessment. Assessment is very important. So some point about the care of the client with a chest tube. First one, assessment. Assessment the client for any respiratory distress or any added breath sound, also stable vital sign or not. Keep in mind the chest tube should be below the chest level, below, and do not milk or strip the chest tube without doctor order. Do not. And daily chest x-ray are needed to check the fluid removal. And client will have occlusive dressing at the incision site. And last one here, never clamp a chest tube without doctor order. And finally, I want to tell you 3 things always bedside. So NCLEX board asks, when a patient has chest tube, what 3 things always be bedside? One is occlusive dressing, then clamp and sterile water. If you ask me, what are the chest tube complications? If the drainage system become compromised, the place the end of the tube into the sterile water, and also if the chest tube is accidentally removed, apply the dry dressing gauze over the area. And sometimes the tension pneumothorax developed. Tension pneumothorax can result from kink in the tubing or obstruction, and symptom is trachea is deviated. Also absence the breath sound on affected side, respiratory distress, and asymmetry of the chest expansion. So this is the very basic information about the chest tube every student must know.